So when we talk of EGFR TKI resistance, extra points for who identifies with this resistance, the resistance who can identify with. So other than that, whenever I used to have these last 2 years, all these meetings in the COVID time, my daughter basically said that, look, you guys live in the land of the Zoomabs. No, she created this whole place because whenever we would talk, we would say Zoomab. And it came to a point where she would say, look, you're talking about what's a Zoomab and I can't pronounce this Zoomab. That's where we were. So what I thought is rather than going through individual one by one paper and possibly talk of things which we don't do anything about, so rather than that, we will just talk of these indications and talk of TKI resistance in this setting. Oligoprogression, progression after first generation or second generation TKI, or first generation TKI with anti-VEGF, or first generation TKI with the chemo, or progression on third generation. And then what do you do if you're using these sequentially? Essentially, that's what I think most of us end up doing in practice, one of these things. And so I thought we'll discuss these points only today. So first of oligoprogression, Dr. Akhil touched upon it in his talk. So if I can start from next, Dr. Murtaza. Oligoprogression, is it now accepted at least among the medoncs? Is it an accepted modality and we treat all our patients with oligoprogression with local therapy?
Yes.
Okay. Anyone on the panel disagrees or? Okay, excellent. So let me ask the more important question. At oligoprogression, when you give radiation, would you do testing for the resistance or not? Dr. Aditya, you're at the corner, so you're targeted.
Yes, sir, I think we should do...
No, do you do or not? Thinking and all that is fine, but do you do? You do testing. So you would do the typical testing for whatever is indicated at that point of time. Very good. Dr. Dilip, would you agree or would you say I'm oligoprogression, I'm going to give radiation, I'm going to do a surgery, I'll just continue my same drug, so I don't want to do a testing?
Basically, if it is a single site bone mets or something like that.
That's exactly what I mean by oligoprogression. You may not consider it. Amit, would you do testing? No testing.
For oligo, no testing.
No testing. Very good. Murtaza, Dr. Murtaza?
If only bone only, then I will not test it. If the other new...
So if you have slight increase in FDG avidity in the lung with all other lesions stable, you would radiate the lung. Would you still do a testing?
No.
You would not do it. Okay, that's what oligoprogression I mean to say. Okay, so Akhil, you can tell us what TMH is doing, which study you are putting into which patient, because that's what I think is the general TMH trend now. Put everyone into a study.
But unfortunately, we don't have any study for this specific subset now.
Okay.
But we are writing a protocol for them same.
That's what I said. Something other you'll be doing. So you're going to do testing. Okay, so in your...
But we do testing in such scenario.
You would do a testing in scenario. So a hypothetical question. Your patient is on this KN protocol, as Ullas Batra calls it, the Norona Kumar protocol or the chemo and Jeftinib protocol. And now patient has had slight progression, you have irradiated him and now you found a T790. What do you do? Would you change your protocol? Would you?
If feasible, definitely we'll change.
So you would change.
As was discussed, 30%, 20 to 30% patients are not able to reach the next line of treatment. That is what.
No, it's an oligoprogression. We are talking of single new bone met. Like Dilip says, single new bone met. I have given radiation to him.
Yes.
He is fine. Still, you would like to test. Okay, interesting. So again, I don't think there's any guideline to this. At least the Western countries would say you test everybody. That's how they do. Would you change treatment immediately on an oligoprogression is something where I really don't know if there's a data on that specifically. So, Dr. Mehta, is there any data which says that, an oligoprogression you have to retest, or can you just go ahead and treat? Because in practice, I guess most of us would just continue treating.
If you find a new mutation and you have the drug available, you'd have to be really brave not to change. I mean, I would not see the reason to do that.
So it's better to be a coward and not test at all, like what the rest of us do. But I'm just joking on that. Yeah, but
you have options.
You have options. Perfect. Great. So let's take now the first and second generation TKIs or the combination of TKI plus this thing. How do we test for these mutations? So Dr. Aditya, again starting from you, would you do only the T790M alone? Do you do the entire panel? Would you do a liquid biopsy followed by the tissue? Would you do a concurrent liquid and tissue, or would you do a tissue alone and say that's enough for me?
So because of logistics, I would do liquid biopsy for T790M. If it is turned out to be negative, then I would go for tissue biopsy.
Okay. Dr. Dilip?
I would do a tissue biopsy and I would test a T790M on that.
Okay, so you do a tissue, would you test only for EGFR? Would you test for the full panel?
So initially I would test only for a T790M, and if it is negative, I might do an NGS.
Okay, so you want to do twice. So you will test an EGFR T790 by what? PCR or how do you do that?
PCR.
So you do a PCR and then you would do that. Amit, in a center like ours, we are all corporates. So
I do a repeat tissue biopsy and do
tissue
a-
biopsy and then
NGS.
and
for all
NGS.
this.
You would not do a liquid biopsy. Okay.
At present, I am not doing, but
Okay, fair enough.
after this might be both.
No, that's okay. That
simultaneous.
will come to the next slide.
Yeah.
Dr. Murtaza, what is in practice that we are doing? Because traditional teaching when I passed out was that you do a liquid biopsy first. If negative, do a tissue and then go ahead.
Sir, we want to save the time also, so I definitely go with the repeat biopsy if feasible and send for the NGS.
Okay.
So it will cover all other probable mutation also.
Okay.
I
Fine
will do
enough.
this.
Dr. Bharat, same.
If the tissue is accessible, I do tissue biopsy and send the concurrent liquid.
So
both-
you'll do
both
concurrent.
together.
Okay. So for first person of this is the Bombay style, I would say. Do concurrent.
No, but listen, you have to evolve your practice
Fair enough,
based on
fair
your
enough.
experiences.
Fair enough. So you would
do-
suggest concurrent. Okay. Okay. So Dr. Vidya, since you are the molecule, now we'll come to you. So in what samples you're receiving, are you finding these people now increasingly doing a concurrent? Because it seems, and what is the concordance rate there? Are you finding in liquid and not in solid?
No, sir. More or less, it's fully concordant between.
Fully
the-
concordant.
Yes.
Okay.
Yes.
Okay, that is interesting because this is the paper which was presented from Taiwan, of course. And what they found was that the concordance rate is not full. You are having only in liquid 5 patients, only in tissue 14, and combination was the mixture. So, they are finding this discordance rate. So, but in
it could be that we have limited number of samples. That's also.
5, 10, 20, Okay, fair enough. But
that is.
okay, interesting.
That could be one of the reasons. But by and large, if you see, one thing is, what are we asking? Are we asking only for the T790M mutation, or we are looking beyond that? That also plays an important role, right?
Wonderful. So that's the next thing that I'll be talking about. Dr. Akhil, TMH experience, I think you also found something similar, right? I think.
I agree that we found some discordance, and if feasible, we also tried to do CFDNA and.
So you try to do both at the same time if feasible.
We try to do.
And if I'm not mistaken, Dr. Ullas also presented his data from RGCI, which showed something similar, that the discordance rate is around 10 to 15%, if I'm not mistaken. So it's a good idea to do both. So again, I think as Dr. Bharat says, you should evolve and try to do both. But more importantly, so Dr. Aditya, now you hear all this and you want to go back and say, okay, everyone, Vizag is like Bombay, I'll do the same thing. No, but then what do you order? That's what Dr. Vidya is asking. When you ask, what NGS do you ask? Do you ask for 12 gene? Do you ask for 50 gene, 200 gene, 500 gene? What do we ask for?
If I have liberty, I will ask for complete panel.
Complete panel means what? Would you do a hotspot sequencing for the major genes, or would you do a complete sequencing? This is the question which I think a lot of people do ask. Because panel, the lab people come and say, sir, you can order a panel. What is there in that panel?
The common mutations which we see, as the resistant mutations are there, MET amplification, head
Okay.
amplification.
So, Dr. Dilip, which lab, do you have an in-house lab or do you outsource your lab?
We have an in-house, but it's not fully.
So you outsource it.
Yeah,
So what is the question that you ask your lab? Which are the mutations they're testing and how are they testing it?
Basically, we send basically a 270 gene panel.
270 gene panel, okay?
So basically, the comprehensive tumor gene panel is what we send. But many people are bringing out this lung panel, separate lung panel also. So
12 gene panel, that the famous 12 gene panel. For last 2 years in all panels I've been hearing only the 12 gene panel. But no, my question is, this 270 gene, are they doing a hotspot or are they doing a full sequencing? Because Dr. Vidya is there, you can ask her. That's the reason I'm asking. Are they doing hotspot for it or are they doing a full gene sequencing?
it's full gene sequencing. So
Full gene sequencing. Dr. Vidya, is that common? I think many labs are actually doing hotspots. They don't do the full gene.
So it depends on the 12 gene panel. So the 12 gene panel essentially, particularly Thermo Fisher assays, almost all those assays are amplicon based assays. Mostly when they say explicitly it is for biomarker driven therapy decisions, it is always only around the hotspot amplification. But something like a 270 gene panel or the foundation or most of the other panels, they would be complete coding region.
Okay. So that's the important thing. Whether they're doing amplicon based, whether they're doing hotspot or not.
But
Okay,
in
very good.
amplicon, usually if you do smaller panels, it would be primarily in and around the driver mutations.
That's exactly why. The reason again, Dr. Bharat, since you said you do liquid and all. So liquid only for T790 or the complete CFDNA again a liquid biopsy as they call it.
So it's not for only T790 because
You do for the full
you end
thing.
up in missing a lot of other mutations.
Fair.
including,
So again, the reason I'm asking is I had this discovery rather, revelation rather when I spoke. Go ahead.
See, the problem, no, you have to speak to the lab because you will get a lot of data. But then we have come in 10 years from sequential testing of EGFR, then all, and now we have so many mutations. At the end, if you have to see whether the drug is also available. Then you
Fair
can
enough.
choose the panel which the lab is offering, and the cost logistics also, no, these are the other issues.
No, the reason I'm saying I had this experience where a patient had only some occasional bone met. I could not get a tissue biopsy. So I said, let's do a liquid. And then I discovered that they actually don't do all the fusions. They were not doing the met amplification, or they were not doing all the fusions what I wanted. So in the liquid biopsy, when they come and tell you that, look, we are doing 12 gene or 50 gene, please find out what they're doing. Dr. Vidya, which are, in liquid biopsy, can you do all these fusions as well as in the solid? Is that?
It is not implied directly, sir. As you said, we have to definitely discuss with the laboratory which has validated the assay, because in liquid biopsy, you are looking at cell-free DNA, no RNA. So in DNA, it means to say that you should cover the intronic region for the fusions to be detected. So that is what Foundation 1 explicitly states, that they do cover the intronic regions. That is why they are confidently saying that they are able to detect the gene fusions in cell-free DNA. So if any other lab says that, yes, we can detect gene fusions in cell-free DNA, that means their design should incorporate the intronic regions, and you should have an evidence of proof that shows that actually the sequence spans the intron on left side with EML4 and on the right side with ALK. So that is when your design means seeing is believing. So essentially that is what it means at the technology level. One has to be confident.
Dr. So for those who didn't understand most of what she said, simply call up somebody who understands and ask them that, look, this lab is doing, are they doing it? Because I had the same place.
So
Yes.
always what happens, we talk about the cost constraint. We should actually have discussion on this background with the lab people, and
Yes.
then you should choose what panel.
Correct. Just because some lab is cheaper doesn't mean they're doing everything. At the same time, some lab may be able to do a cheaper test, but include all this information. So if you want a patient on osimertinib, you want to see if they're MET14, or you want to see if they're MET amplified, and your test is not looking for that, there's no point in doing that test. That's the point that I want to bring about. Just don't say to the lab that, look, I want to do liquid biopsy. Liquid biopsy means plenty of things. What exactly is being tested has to be understood. And again, a lot of us don't understand it, so you call up somebody who does understand it, your senior or your friend or whoever, and find out what they're doing. So that's the point that I was trying to bring out with this sort of discussion. So again, yes, ma'am.
So till now, whatever why hotspots came into picture in first place is because the early on when drugs were discovered as part of clinical trial outcomes, they specifically knew which mutation had the good response rate. Then life wanted to be much more easier and cost effective, so we went for hotspots. But now as we started evolving, if you see osimertinib resistance, there are more than 12 to 15 new mutations. Lot of patients we have seen now with osimertinib progression. And there are new mutations in the kinase domain of osimertinib. And that is a new learning for all of us. So in such a scenario, when T790M was discovered, we all knew it so well because nearly 50% of NSCLC when it progressed had T790M. So that was the value add that we got from the biology of the disease. But when it comes to the newer drugs, unless we sequence the complete kinase domain, which has an impact on drug binding site. So the drug binding site is the one which gets altered. So that's why sequencing around is very important. In short, amplicons may not help to look for mechanism of resistance. We have to look at complete kinase domain or the kinase.
So I think one thing, if I can also say, this is very important when you have some allosteric inhibitors or you have inhibitors which will target that other side. I think I'm with Madam on this that, you find that also which is an unusual mutation, you're not going to do anything about it. I think that's what I think ma'am says, and I agree with that. We don't have those novel type of therapies anyway. So these are the basic some of the mutations which occur, the basic pathways which are affected in the resistance pattern, which is what we test for and look for it. So what are our treatment options? So the first question, again starting from Aditya, T790M positive you have got, would you consider only osimertinib, or at any point are you considering this combination, Osi, Bev, Osi, Ramu, or whatever you want?
As of now, I'll consider only osimertinib.
Only osimertinib. Dilip, only osimertinib. Okay. So this was the papers that have shown. A lot of the Erlot Bev papers have come positive. Again, none of them have actually shown a HR for a OS. They're all showing a very good PFS advantage. They don't have a OS advantage. And this was the paper which was discussed, the booster study. Now, this is the booster study which showed that the PFS was around 15.4 to 12.3, but the OS was really not met. So, anyone on the panel, Amit or Dr. Murtaza, you want to use Ossi Bev as of now for anybody on a T790 or upfront, or would you still stick to only osimertinib?
With Ossi, with Bev, I don't think so. With Erlo, with ramucirumab, there is still data.
The study is coming. The data is not out as far as I'm aware. I don't know if it's aware. Akhil,
The study has been discussed. It is found to be not efficacious.
Okay. Akhil, OC Ramu data, is it out? I'm not aware of it.
OC plus Bev is out.
Bev is this one, the orchard and what we are seeing, the booster and the orchard.
Ramu, I'm not aware.
Okay. Okay, fine.
But I don't think that it will be much different.
You don't think it will work. So again, this is the enhanced signals that they found. They said, tobacco exposure leading to TP53 mutation. If TP53 there, it works well with the VEGF inhibitor. Anyone has any experience in this? Anyone has used this combination? Anyone in the hall has used this combination, Ossi, Bev, for any reason and found a benefit? I mean, Bev is cheaper than what it used to be, so I guess.
Might be in few cases of a CNS meds where the patient is progressing on Ossi, I have added Bev in there.
You have added Bev.
Sure.
Okay, that's an interesting way because Bev is going to the blood-brain barrier like that, you think? Okay, interesting. Akhil, any experience from TMH side doing these combinations?
No, we don't use that combination, but we try to utilize OC160 in such.
That's okay. OC160 is a different ballgame. I'm not talking about that part. Fair enough. So again, this is a potential thing that can come in future, so it will be something interesting. What if you get the T790M negative? So Dr. Bharat, T790 is negative. Patient is on osimertinib already. What do you do?
So basically, I have personally tried adding chemotherapy with first generation also as well as with second generation. Though the toxicity you expect with afatinib, one of my patients is doing very good with no.
So post osimertinib, afatinib plus chemo.
Negative, I use chemotherapy also in those patients who don't afford those quadruplet of immunotherapy with chemotherapy.
Okay, we'll come to that later. So immunotherapy is one of the options. So would you consider it as an option?
No, because the patient is upfront EGFR positive, and then second line you.
Second line, yeah.
No.
You would not. So you would strike chemo with a combination of a TKI or only chemo?
Yes. So obviously it is not a progression where you try.
No, not oligo. Oligo we have done with. We are done with oligo.
So I have tried continuing the TKI and added chemotherapy.
TKI
Fortunately, I was
okay.
I had good responses in a couple of patients.
Okay.
So I continued that practice, though there is no strong data to suggest that.
Dr. Murtaza, your practice, what would you do?
I will start with chemo with
chemo and Bev. Okay. Okay. Chemo and Bev in that form.
if patient is PS is fair enough. But I'm totally agree with Dr. Bharat Sarag. I have seen some patient who have not got much more response with the chemotherapy, and then I put on afatinib after osimertinib. They have responded. Some 6-7 month PFS.
Did you do the C797 in that cases, or were you? Or the reason I was going, afatinib is supposed to work in that setting. A little bit more. Okay, so the second mutation was not tested for. Okay. Amit, what's your practice? Tomorrow patient comes to you, you have done your panel, you have done which is negative, T790 is also negative. What do you do?
Chemotherapy.
Only chemotherapy. Your choice?
Pem-carbo.
Pem-carbo. Very good. Dr. Dilip?
Chemotherapy, and I might consider continuing the EGFR TKI.
You'll continuing EGFR TKI. Okay. So interesting, lot of variations in what everyone is saying. So it's interesting that people are doing all this. Aditya, what do you normally do?
Comfortable chemotherapy alone.
You will be comfortable with chemotherapy alone. Again, Akhil, any analysis of your data or TMH data which says, I guess it's difficult because you'll be anyway testing everybody.
Yeah. So if you're doing comprehensive testing and you're detecting anything else.
Anything else is not detected, assuming that nothing else is detected. That part, of course, you know what to do.
We have tried ABCP, we have utilized,
okay.
but tolerance has been really very poor.
Okay.
From that time, we have shifted to weekly paclitaxel
Okay.
instead of 3 weekly paclitaxel.
So not PEM carbo, because that's the other thing which people ask. Pemetrexed versus paclitaxel. So you prefer paclitaxel.
If we are utilizing in combination with atezolizumab,
Okay.
then we use weekly paclitaxel.
Okay.
That is now what we are doing. If patient is not afforded for atezo, definitely we utilize PEM carbo bev.
PEM carbo and BEV. Okay, so BEV addition is something that we are considering. Would anyone want to add immunotherapy in EGFR? No, Bharat has declared it. Okay, EGFR, I'm not using any time immuno. Is that a standard of care now? Aditya, anywhere EGFR positive, would you want to also give immunotherapy?
The combination of atezolizumab,
ABCP. Okay, so again, ABCP is the thing which use 9% EGFR, so we are basing it on that 9%. Remember, atezo or BEV, what has improved, we don't know. Because there's no arm of atezo and CP. There was no atezo single arm in that. So you'd still be okay to use ABCP.
If I have to use immunotherapy, then
No, you don't have to use. The patient is with you. You can do whatever you want. You don't have to. Nobody is forcing you to use atezo in this case. That's why I'm asking. Would you use atezo? Is the question.
if affordable, I may consider.
Okay. So,
Single
Dr. Dilip.
agent immuno has a response rate of around 12% in EGFR positive that we keep in mind. And according
I am with Bharat on this. Maybe a similar thinking, but I am like no EGFR positive. Forget immuno because I have not found any benefit anywhere in any trial.
ALK 0% benefit, EGFR around 10 to 12%.
10 to 12%. Dr. Dilip.
I would not consider immuno.
No. Dr. Amit.
No immuno, but it's something. Similarly, I have a patient last week with a post-progression on PEM carbo-JEF, basically. PDL1 coming out to be 70% on the repeat biopsy. And all other
On liquid biopsy?
No.
On the tissue biopsy.
Tissue
Okay, okay.
biopsy.
Use. Adora. We are looking at, adjuvant immunotherapy. We are looking at neoadjuvant immunotherapy. Everywhere they're excluding EGFR. And wherever they've included, it doesn't seem to work. So, Pacific, there's a clear study which said that if EGFR positive, it doesn't work. So, should we use immuno at all? I mean, I am with you on this.
The message is very clear. No, whatever data we have now we have discussed in so many meetings, we should exclude it. The only thing, if somebody comes with nowadays patients come with the report rather than you advising them, and the patient comes with the MSI high with the
MSI high, of course,
data,
separate issue.
I would know that
Yes.
will not keep
Completely
everything aside
disagree.
because you have limited options. Why
Okay.
not to use immunotherapy?
I agree with you on the MSI high, possibly I'll be tempted. PDL1, definitely not. In fact, I won't test it at all. So, Akhil, what your take? Again, me and Bharat are saying, every study across adjuvant, neoadjuvant, and metastatic, EGFR and immuno don't seem to work. What do you think?
Definitely. Limited benefit, again, I will say. So benefit is 10 to 12% only.
Okay.
Single agent drug. So if a drug has single agent activity, then only it merits combination. Otherwise,
I-
it doesn't merit combination.
I completely agree with you on this. I don't think immuno in whatever that ABCP, we have discussed it ad nauseum, it doesn't really seem to work well. So this is what we have already discussed, what is the option, and most people do say either chemo and anti-VEGF, which is a decent option. And newer options are of course coming in. You have savolitinib and tepotinib. These are all in trials. The TATON was running in a few centers in India, I think. So one of my patients post osimertinib went on the trial and did well for 1 year. So that's something we can consider if we have trials. Again, not often that trials are running. I'm not aware of any trial running right now, but I'm sure it must be there. So what about this? This was the paper again presented by the previous speaker, Orchard study, which was basically a failure. Now, what they tried to say that the objective response rate should be at least 45%. Akhil was saying 12% response rate with atezo single agent, and they were looking at 45% and it did not work. So it failed here. So again, immuno with this, don't know. This, remember, was a phase 2 study. Interesting, they tried to compare with an older group of historical control and then said there's a benefit in terms of PFS by addition of atezo. Again, I don't think this is something I'll really be believing much because it doesn't seem to work anywhere else. So there's no reason why it should work in this one small study of around 25 patients and then say 50 patients of historical control over 11 years. It was 2009 to 2020, and then say that we'll use this combination. So again, I'm not sure the approval might be there, but personally, I don't advise this nowadays for patients. 797S, the Boeing 797, by the way, has been discontinued for reasons best known to Boeing. It was a new model in their entire plane, the 737, 747, 757, and so on. But this has been discontinued apparently. Anyway, we are talking of the C797S. How often do we encounter this? Dr. Bharat?
Encountered last month only.
Oh, last month you found a
So
patient?
this patient was T790 positive before, and we missed in
Now
that.
has come 797.
Responded to osimertinib couple of years.
Wonderful.
2 years. And then this time we missed in liquid biopsy, and I categorically said do a solid biopsy, and then this was positive. Now
Oh, wonderful.
The drugs are now, there are very limited options in terms
So
of.
again, the question which was being discussed in Akhil's meeting, would you do cis or trans? Did you ask them for cis versus trans? Cis 797 versus trans 797. Again, this is something Akhil was talking about, and I think we should test. Dr. Vidya, for the benefit of the audience, how do you actually do it? I mean, I don't know how it is tested. Cis versus trans.
It's very simple, sir.
If you can just speak in the mic.
Hello. So codon 790 is T790M, right?
Okay.
T790M.
M.
It is the 790th amino acid. You just have to hop 7 amino acids from there.
Okay.
It will be in the same DNA segment.
Okay.
Okay. So for each amino acid, 3 alphabets, right? A, T, G, whatever. So you are essentially hopping 15 alphabets from there.
Okay.
So you got a T790M at 1 alphabet, and you hop 15 alphabets from there on the same thread. If you see a mutation there on the same thread, it is called cis.
Okay.
But if you see a mutation in the complementary strand,
Then it becomes
then
trans.
it becomes trans.
Sounds very simple, but again, like Akhil was saying,
Meaning- So essentially, what we are trying to say here is, why it is cis or trans, essentially what we, biologically we all understand, that is, in cis, both the mutations are happening to the same clone. So it is like tracking on the same road. So when you are tracking on the same road, you got the first obstruction, which is your T790M. You keep walking on that same road, you got the C797S also. That means you are on the same track. But if you had a parallel track where you got the C797S, that is a different clone.
So that's why they do worse. The trans will do worse.
The trans will have an efficacy of geftinib.
Or will have an efficacy still there.
Because
All right. So cis
the
is bad, trans is better.
The trans did not have T790M, right? So
Okay.
it does well.
See, this is why I do panels. I learn so much from the panelists. I had understood something about it, but I did not understand. So, Bharat, this is the question we should have asked the
hope I
panelists, but
It is so easy, see Vamsi.
exactly. So this is again interesting because I have not found a C797S, but again, in at least the data says it's the most common EGFR mutation. So, Akhil, how much in TMH? 6% is I think what you were saying, or
6 to 7.
6 to 7%. Dr. Vidya, how many are you seeing in your?
We also do
6 to 7%.
some
Okay. So I am not in that 6 to 7%. What is the therapy in such cases? Dr. Bharat, what are you planning? Chemo?
So we had discussion about the case, then this cis and trans we discussed, and the first generation TKI also sometimes
Works. So
otherwise
chemotherapy alone. Great. So again, this is what the study was done about these 4th generation TKI. We are not going to be there. All these alphabets, they are not even given a name to it. So I don't think any of us is seeing it unless they bring in a trial in India. So till that happens, we'll be in, at least know this much about the cis and trans and appear smart enough to ask the pathologist, what is this? So, they will think that you know something which we know.
Just one thing.
Yeah.
Cis and trans. So whenever you do sequencing, it is not double stranded, it is a single stranded DNA.
No, what I meant
So-
was in the reads.
Yeah, right. So that means the DNA which is showing you the C79S mutation, that may be from the other cells, not from the
So
same.
when
same
you
cell.
read it,
Yeah.
there'll be a sequence. You're finding in the
DNA
same
sequence.
sequence T790M and this one. So then you know it's cis. If you're not finding this and that, then it becomes
So
trans.
essentially, FFP DNA fragments are short fragments, right? FFP is a fragmented DNA, right? Generally, the size of an FFP DNA is about 150 to 200 alphabets. That's all. So whenever you do this NGS or Sanger real time, whatever you do, but Sanger real time, it's a black box. Nobody knows what is exactly happening
So
there.
I think
But
Dr.
in
Vidya will do one.
NGS,
If you can wrap up quickly, we have 30 seconds
I'll
left.
just quickly say, so this essentially every time you pick up your DNA molecule, you are only reading that 150 to 200 alphabets. And each alphabet, it's a pool of tumor cell DNA, right? You don't know from which tumor clone it has come. So if you had a clone, from a clone, you had both the dots at T790M and C797S in the same thread. That means it belonged originally to one cell. But in another cell, it was not there. It had no T790M but had a C79. Yeah, there are
So you
essentially
need to
two
know which
clones.
is more, and if it is mostly
Yeah.
non-T790M, then it is trans. If it is
Yeah.
mostly together, then it means it's a cis.
Cis.
Okay, that's the understanding that we have.
you're
Excellent.
right, yeah.
So we are out of time, so I'll not talk of the MET exon 14 sequencing skipping mutation. We have a drug available, and we are occasionally using it if we get it. BRAF, again V600. Now a tissue agnostic approval is there. We have the drugs in India. I don't know how easily we get it or how commonly we get it, but that's about it. So thank you everyone, and again thanks a lot to the yes, ma'am.
I
You
have
want?
one
Yes.
small comment here.
Yes.
Nearly 30% or 20 to 30% of the cases post EGFR TKI, we are seeing small cell transformation like biomarkers. What are we doing there?
Small cell, we all just give
small
chemo,
cell like biomarkers.
not the histology. We are still relying on histology.
But this is small cell like biomarkers.
I have not
Are we
encountered
one-
it, so I don't know what to do in it. I leave it to the
see that,
audience to decide.
Actually, we are seeing a lot of that.
I see. This is an
are we
interesting. I
one-
think we should take that
Yeah.
conversation offline and see who all are picking up that kind of mutation and then decide what to do with it. So Vijay is not there. Otherwise, Vijay and Akhil, you can help him write a new protocol for that. So thank you, everyone.